Assalamu alaikum. Bismillahirrahmanirrahim. Assalamu alaikum to everyone. We start with the session of Bone Marrow Failure Syndrome. I'm going to moderate the session. And to start with the session, I would like to welcome the chair of the session, Brigadier Asad Mahmood. He's commanded at Armed Forces Institute of Transfusion, Rawalpindi. He's professor of pathology and he was former head of Department of Hematology at Armed Forces Institute of Pathology, Rawalpindi. Now I invite my co-chair of the session, Dr. Mohammed Nadeem. He is consultant hematologist at National Institute of Cardiovascular Diseases and its satellite center. He is presently working there as a head of pathology. He is a CPHD approved supervisor of hematology. He has a special interest in molecular and cytogenetic analysis. I welcome Brigadier Asad Mahmood and Dr. Mohammed Nadeem as a chair and co-chair of the session. Now I would like to invite my panelists. My first panelist is Dr. Zafar Hashmi. He is a Parsipath and one of the pioneers in the field of hematology here at Karachi, Pakistan. He is presently affiliated with Sindh Institute of Urology Transplant Center. He is a former president and founder member of Pakistan Society of Haematology. He has many publications in peer-reviewed journal. He is now member editorial board of JPMA, Pakistan Journal of Pathology and Journal of Hematology. My second panelist is Dr. Nadir Ali. I welcome Dr. Nadir Ali. He is consultant hematologist at Khurram International Hospital, Islamabad. He has more than 60 research publications in peer-reviewed journal. He's been secretary PSH, and now managing editor of Journal of Hematology and Stem Cell Research and official journal of Pakistan Society of Haematology. My third panelist of the session is Dr. Farrukh Ali Khan. He is head and program director of clinical hematology and bone marrow transplant at DAF University of Health Sciences, which is the first public sector of the province Sindh. He has a special interest in leukemias and bone marrow transplant. My fourth panelist is Professor Dr. Waseem Iqbal. He is currently working as chairman and director clinical labs in the Department of Pathology in Fazaya Rutba Medical College. He is founding member of Pakistan Society of Haematology. He has numerous publications in reputed national and international medical journals. And my fifth panelist of the session is Dr. Khalid Hasan. He's a professor of pathology and currently working at Islamabad Medical and Dental College. He was former president of Pakistan Society of Haematology and College of Pathology. He is editor-in-chief in Journal of Islamabad Medical and Dental College currently. He has more than 100 publications in many reputed national and international medical journals. Now I would like to invite my speakers of the session. I am really happy to call my first speaker. He is Dr. Ghulam Nabi Kakepoto. He's consultant hematologist at Royal Wolverhampton Hospital, United Kingdom. His primary interest in red cell disorders. He is going to deliver talk on an update on inherited bone marrow failure syndrome. So let's start with our first talk. Over to Dr. Ghulam Nabi.
Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, I am Dr. Ghulam Nabi Kakepoto. I am working as a consultant hematologist here in the United Kingdom, and I'm really thankful to the organizers of the annual conference of the Pakistan Society of Haematology to invite me to talk to you about inherited bone marrow syndromes. What I'm going to do today is mainly talk on the first three ones, which is Fanconi's anemia, Schwarzman diamond syndrome, and Discarotis congenita in view of the limited time available. These are the ones which typically present with the kind of a trilineage dysplasia, yet others generally present with the single lineage like diamond blackfan, which typically presents with anemia. Fergus anemia is well known to us. When I was in Pakistan, I have seen cases. It typically is an autosomal recessive disorder, but rarely there are cases of X-linked. It causes progressive bone marrow failure, and sometimes people present when they are adults. They've got a number of somatic abnormalities, which may not all be present in one patient. So we have to look for them, and sometimes there's nothing present. And these people are typically predisposed to malignancy, like acute leukemia, and sometimes they even develop solid tumors, particularly epithelial tumors. If you look at the somatic abnormalities, most people would have abnormality in the thumb or in the radius, which is sometimes absent or rudimentary. They've got skin problems, either hyper or hypopigmentation. They are short-statured. They have eye problems. They can have horseshoe kidneys. They can have a mental retardation, hearing problems, and they can have microcephaly with mental retardation. Sometimes nothing. If you look at the pictures, you can see the hyperpigmented areas and sometimes hypopigmented areas. And if you look at the hand and arm pictures, sometimes there's absent radius and rudimentary thumbs or completely absent thumbs, and sometimes severe kyphosis. So these people typically present with the bone marrow failure, and we go on to do the bone marrow. Sometimes we just find classical aplastic anemia, or sometimes there are MDS changes, and sometimes they are even presenting in acute leukemia state. So we need to keep our mind open that, say, somebody is presenting with acute leukemia, we want to make sure that, particularly in a child, we want to make sure that we are not missing Fanconi's anemia. And we should also look for other somatic problems when we are examining them. So thorough examination is very, very important. And relevant investigation, including skeletal survey, abdominal ultrasound, and lung function, are very important. Let's look at the bone marrow chromosomal breaks, which is the gold standard for the diagnosis. So these children have chromosomal instability because of the absence of Fanconi anemia complementary genes. And this leads to really the kind of sensitivity of these chromosomes to excess breakage because of the certain agents like cross-linking agent like mitomycin C or dioxybutane. Most people use mitomycin C. We use it here in our lab, mitomycin C. And if you look at the breaks on the right side, when mitomycin C was added in the karyotypic culture, you can see lots of breaks as compared to the normal one on the left. If you look at the, sometimes we don't find any chromosomal breaks. There was a publication by Pinto, which showed that a number of people, I think they quoted about 10% or something, they didn't have any chromosome breaks on conventional lymphocyte culture. So they used skin fibroblast culture and with mitomycin C, and found that about 10% further people were diagnosed with Fanconi anemia. But it's very important to keep the mind open that even if you don't find conventional breaks on mitomycin C culture, you should think about it if you have suspicion that this could be Fanconi anemia. A commonest one is the Fanconi anemia complementary A gene, which is on 16q. It's a quite large gene, and that's why it was missed in the early publications. And the other important thing I want you to look at is the red one, BRCA gene, which, as you probably know, is associated with ovarian cancer and other gynecological cancers. And this is very important in terms of really the complex that helps in maintaining the chromosome. The other ones are rather uncommon. So let's have a look at the complex, where this Fanconi anemia complex helps in maintaining the chromosome. And because of the mutations, it kind of fails to add certain important ingredients to the complex, which is also held by the BRCA gene. And then the DNA repair is lost, and the chromosome is unstable. And also the p53 gene also gets activated, leading to the chromosomal breaks. What do we do with them? If we are certain that this is aplastic anemia, which is really very important to make sure that this is Fanconi anemia, not idiopathic. I'll come to that in the later part. What do you do if you're not sure? So supportive is the main thing. So initially you support them with blood platelets and antibiotics. Many would respond to anabolic steroids and sometimes Irazole. A certain percentage may not respond at all to anabolic steroid, or they then later fail to have further continued response. So in that case, hematopoietic stem cell transplant would be really needed. I'll come to that in a second, what consideration you should have in doing the transplant. There's a lot of work now going on in terms of the hematopoietic gene therapy. I'll come to that in a minute as well. So in terms of transplant, conventionally we have been using quite hard doses of cyclophosphamide, which caused a serious problem in these children, and many wouldn't recover, and or they had a later quite serious malignancies after the transplant. So modified protocol were used with quite smaller dose of cyclophosphamide, which were really pretty good and had successful transplants. This is data from a colleague, Dr. Inderjeet Dogal, who is a professor at Queen Mary Hospital, Queen Mary University Hospital in London. If it's a sibling, identical sibling, the chance of the successful transplant and reasonably good quality of life is pretty good. But in mice unrelated and family donors, which is haplo, the chances go really down. And as you know that there are only limited people would have identical sibling available. This is a typical protocol which is being used with fludarabine and lower dose of cyclophosphamide along ALG, and which is being successfully used. I was speaking to a colleague at Aga Khan. She said that a similar kind of protocol is being used there as well. Genes. Lots of work has gone into the genes, and there was a recent publication which showed that a corrected gene was inserted in the stem cell of the patient, and these stem cells were reinfused without in conditioning, which is very interesting, without in conditioning, and they homed in and started making successfully a normal product, and it survived over a long period of time. So this looks really very convincing, and particularly with the availability of now CRISPR technology, I'm sure that there's a lot of progress which is being made. We would be able to offer some hope to these children. The next one is the Schwarzman diamond syndrome, which is again a multi-system disorder, and it is again autosomal recessive with some exocrine pancreatic insufficiency and bone marrow failure, and they also have somatic abnormalities. We're very careful in making sure that we are not talking of Fanconi or Schwarzman. And they also present with cytopenias, and they have got a typically isochromosome involving 7q, and they also have a predisposition to acute leukemia. They tend to have, quite a number of them would have a myelodysplasia, and a good majority of the patients are males. They can present even later in life. These are the early precursors showing dysplastic changes in the marrow of one of the patients. Isochromosome is seen on a typical karyotype in these patients. The Schwarzman product is a protein which really helps in ribosomal biogenesis. So this is a ribosomal disease which really helps in so many proteins. Thus, it is a kind of a multi-system disorder. And it has also been seen that the diamond blackfan anemia have also got a similar kind of problem. You give them pancreatic enzymes, creon, and bone marrow support with the supportive therapy, blood platelets, and GCSF support you can do. And bone marrow transplant will be of similar low intensity with fludarabine. Dyskeratosis congenita is X-linked disorder, hallmarks are abnormal skin pigmentation, nail dystrophy, and leukoplakia. I'll show you the pictures in a minute, and many would have a bone marrow failure. So hyperpigmented areas, significant leukoplakia, some would have really subtle leukoplakia and abnormal nails, some more pictures, quite gross leukoplakia and quite abnormal thumb nails and pigmentation. I want you to concentrate on the red one. Many would have a pulmonary disease, and they are also predisposed to malignancy. As they grow older, the chances of bone marrow failure increase. And it's a stem cell disorder with the coliformic units here, they are really at the bottom as compared to the normal. Typically X-linked, but sometimes autosomal recessive or dominant. I'll come to that in a minute because there are other genes which are involved in this complex. Typically, initial gene was a discovered congenital gene, which was mapped to XQ27. But lately, other genes have been found which are autosomal dominant or recessive, like TERT, and TINF2. And these all genes help in maintaining the health of the telomere. So these are called telomerosis. And this mutation, particularly A353V, has been found quite recurrently. There's a variant of this syndrome called Hurral syndrome, where it's quite severe syndrome with low birth weight, development delay, microcephaly, immunodeficiency, and bone marrow failure. I'll cross that. And in the complex, which helps in maintaining the telomere along with the discarin, which is the DC gene, along with TERT and other genes, the products help in maintaining the telomere. And if any one of them is affected, there is a shortening of the telomere, which is progressive in the stem cells, and there is stem cell apoptosis. And this is typically seen in rapidly dividing cells like bone marrow. So I was talking of finding some telomere problem. People looked at the idiopathic aplastic, where they did the exhaustive investigation, just make sure that it's not something inherited. And they still found that in some people, there were short telomeres. Now, the question is, because some of them also go on to develop acute leukemia. So question is whether this is discarded congenital, or this is really just idiopathic aplastic anemia. Difficult to say at the moment. So about 5% of these people would have a telomere problem who are idiopathic aplastic anemia. So on one side, you've got a classical discordance congenita. On the other side, you've got a very severe Hurral syndrome. And on this side, you've got aplastic anemia which may be either with subtle some dysplastic changes or even acute leukemia, and they may have this defective telomere. As I mentioned, that mutations in the TERT and other genes help in maintaining the telomeres. I'll pass that slide, and I'll come to that, the cancer area. A number of these genes help in maintaining the telomere, and the excess damage leads to the stem cell depletion, and this kind of predisposes the cells to cancer development. I think it's important that the physician is fully aware of the problem, and it's kind of multidisciplinary area, so the patient can present to any of the specialty. So they're very important. Also, in these people, it's important to avoid environmental agents like smoking and other drugs, which might exacerbate the problems. Again, management would be initially supportive with blood and antimicrobials. Anabolic steroids can be used, and even ordinary steroids are sometimes used, but I think eventually these people would need a stem cell transplant. the data from, again, in the Jidokal, showing that the fluorabine-based reduced intensity transplant, where they had a quite successful transplant, 29 over 36. So what investigations should we do if you get a patient with such kind of situation? You look at the peripheral blood very importantly, look at the reticulocyte count, look at the peripheral blood film, look at the bone marrow very carefully, make sure that there are no dysplastic changes. And then also, if it's classically aplastic, you go on for a really detailed investigation with the chromosomal breaks for Fanconi anemia and a mutation analysis. We use here next generation sequencing, where about 100 genes are looked at, including dyskeratosis TERT, TINF2, and also the myeloproliferative genes like JAK2 gene, BCR-ABL, MPL, and all these genes are looked at. Just make sure that we are not missing anything. So I think it's very important that if somebody, a particular child with suspicion of one of these syndromes, it's important to do a really detailed investigation to rule out any such disorder. Also telomere length, which can also be looked at pretty easily using the flowfish, which is a new technique around nowadays. I really don't want to go into the details of that. Also, we should look for somatic abnormalities, which will help in defining the diagnosis, particularly like skeletal survey, lung function. We should also look at the echocardiogram. Some of them are cardiac problems. Abdominal ultrasound, just to look at the kidneys, and also the exocrine pancreatic function. I would encourage to do the fibroblast cultures, which I think now it's quite possible in Pakistan, because now people have really taken up with these kind of things. So if somebody who presents with the aplastic anemia, typically, if you think that it's inherited and the diagnosis is clear, you can start with the supportive and oxymetholone. If there is no response, you go for the stem cell transplant, or if they fail to respond or later fail, then you go on some kind of a transplant or experimental therapy. If it is classically idiopathic, typically we use, again, depending upon the availability of the donor, we would go for a stem cell transplant or immunosuppressive therapy, depending upon the availability of the donor. So, in conclusions, aplastic anemia is not uncommon in Pakistan. Whenever I talk to my colleagues down there, they say that they have got lots of patients. And many times it is idiopathic, and I'm sure you are doing all exhaustive investigation, just make sure that it's nothing, something like a syndrome that we talked about. And before you institute treatment, it's very important that you should thoroughly investigate them, give them a really full clinical examination, all the investigations that are suggested, and all the high-tech investigation. I'm sure the next generation sequence is not available in Pakistan, I understand, and you can really use that to exclude any Fanconi's, Schwarzman, or dyskeratosis congenita. So I will stop here, and I shall be quite happy to answer any questions if you have.
Thank you so much, Dr. Ghulam Nabi Kakepoto. It was a great talk. Thank you for your enlightening speech at PSH Forum. We will take question and answer at the end of the session in panel discussion. Now, I would like to invite my second speaker of the session, Professor Dr. Parvez Ahmed. He is one of the pioneers in the field of hematology and bone marrow transplant in Pakistan. He is instrumental in establishing 2 additional bone marrow transplant facilities in Pakistan. One is Gambhar Institute of Medical Sciences. Another is Thalassemia Welfare Society, Rawalpindi. He is one of the founding president of founding president of Pakistan Blood and Marrow Transplant Group, former president of Pakistan Society of Haematology. Presently, he is working as a hematologist and director BMT program at Quaid-e-Azam International Hospital, Islamabad. He's going to deliver talk on management of aplastic anemia in resource-constrained environment. Over to Dr. Parvez Ahmed.
Bismillah ar-Rahman ar-Rahim. Thank you for asking me for this talk on aplastic anemia. It's over 2 decades now that I have been associated with aplastic anemia, starting from the epidemiology of aplastic anemia to management, diagnosis, as well as management and longitudinal follow-up of a large cohort of patients. The incidence of aplastic anemia is said to be 2 to 3 per million per year in Western Europe as well as in North America, but it is 4 to 5 times higher among the Asian populations living there as well as among Asian countries. Coming to incidence of aplastic anemia in Pakistan, there is no registry here, but we did an exercise in 2017 and we calculated total of 651 new cases of aplastic anemia during that year by collecting data from all tertiary care hospitals. But there is a caveat in it. Since according to Pakistan Bureau of Health Statistics, only 45% of the patients for any disease ever reach a tertiary care facility. If we keep that into account, the incidence would be something close to 7. This is a nice review by our team in collaboration with EMBMT and EBMT for special issues related to the diagnosis and management of aplastic anemia in resource-constrained countries. This is a busy slide, but just I want to highlight that if we concentrate carefully on the history and family history, we can get clue whether the patient has got underlying inherited bone marrow failure syndrome or it is acquired idiopathic aplastic anemia. Similarly, by concentrating on certain features in the bone marrow, we can get some clue to rule out the related disorders like hypoplastic MDS, hypoplastic acute leukemia, PNH. And once we rule out these, we are guided towards the diagnosis of acquired idiopathic aplastic anemia. And majority of the patients here we see they either have severe aplastic anemia or very severe aplastic anemia. Now, these are the various challenges that we see in resource-constrained countries like ignorance and illiteracy. There is urban versus rural population disparity. More facilities are concentrated in the urban population compared with the rural population. This all lead to the poor hygiene because of illiteracy and recurrent infections. Then there is delay in diagnosis that can cause late referrals, multiple infections, immunizations leading to various comorbidities. There are resource constraints that can cause suboptimal pre-BMT care, delayed transplant because of inadequate finances. There's malnutrition and comorbidities. Then people, they would prefer to go to faith healers and the traditional practitioners. They would use steroids and antibiotics indiscriminately. This would cause fungal and bacterial infection and immunosuppression due to steroids. Then there is lack of quality transfusion services. This can lead to transfusion transmitted infections. There is absence of leukodepletion. There is people who transfuse whole blood. This can cause alloimmunization, leading to iron overload, graft rejection, and GVHD following post-transplant. Then there is non-availability of essential drugs. This would cause suboptimal management and multiple complications. Now, all these things, they can lead to unfavorable outcome of aplastic anemia. Now, supportive care is meant to alleviate symptoms of pancytopenia as a bridge to specific therapy, whether it is immunosuppressive therapy or bone marrow transplant. Major causes of death in aplastic anemia are either infections or bleeding complications. So aim of supportive care is to reduce the risk of infection by observing various precautions and addressing in the bleeding in case of there is a high risk of bleeding. Then adequate hygienic precautions we teach to the patients to avoid exposure to the construction site to reduce the risk of mold infections. Then avoiding use of raw food and uncooked vegetables that would reduce the risk of infections. Repeated hand washing, oral care, general body care, and then antibacterial, antifungal, and antiviral prophylaxis for selected cases of very severe aplastic anemia and high-risk cases. Transfusion trigger for hemoglobin is we recommend as less than 7 gram per deciliter, and for platelet we recommend 10 into 10 raised to power 9 per liter. We should know that repeated red cell and platelet transfusion would increase the risk of immunization, alloimmunization, and that can cause platelet defectiveness as risk of graft rejection. I personally recommend transfusion trigger in platelets once the count is less than 5 instead of 10 in asymptomatic patients, and less than 10 when there is any sign of bleeding. For febrile neutropenia, we recommend platelet cutoff value of 20. And for potential BMD candidates, it is recommended to get the leukodepleted and irradiated blood products. I've been using granulocyte transfusions in certain selected cases in very severe aplastic anemia, but there is risk of lung injury and other potential adverse effects. So it cannot be recommended as a routine. There is no evidence to support the use of erythropoietin or GCSF for the treatment of aplastic anemia. The immunosuppressive therapy responses to rapid ATG are disappointing, while high responses are seen with horse ATG plus cyclosporin and eltrombopag if we combine all these. Many patients do not survive immediate cytopenia that results from ATG administration, and some would not survive long enough to witness the response following ATG-based combination immunosuppressive therapy, since there is prolonged cytopenias following ATG administration. Frontline IST is recommended for non-severe aplastic anemia who are transfusion dependent and having bleeding or recurrent infections. For severe and very severe aplastic anemia, we recommend IST if the patient is transplant ineligible. Cyclosporin alone has been used for the treatment of acquired aplastic anemia. There are various studies and responses reported have been less than 10% to up more than 50% has been reported by the use of cyclosporin monotherapy. We, in a cohort of 355 patients at Armed Forces Bone Marrow Transplant Center, have used cyclosporin alone with overall response rate of close to 31, while the responses seen in non-severe were the 54 compared with the 28% among severe aplastic anemia and less than 10% among very severe aplastic anemia. So cyclosporin monotherapy can be used in selected patients if they have got non-severe aplastic anemia and there is no access to proper immunosuppressive therapy like horse ATG or eltrombopag. Combination of cyclosporin plus horse ATG has resulted superior response rate ranging from 40 to 68% in various studies. Horse ATG has been associated with higher responses compared to the rabbit ATG in majority studies. According to EBMT and Spanish data, rabbit ATG is more immunosuppressive and has been associated with the higher risk of infectious complications. So there are high risk of infections following the rabbit ATG, as well as the responses are inferior compared with the horse ATG. So it's not the recommended treatment modality for immunosuppressive therapy. Addition of eltrombopag to standard immunosuppressive therapy has yielded marked improvement without increasing toxicity. but the cost of adding eltrombopag to cyclosporin and horse ATG is prohibitive in most of the resource-constrained countries. In our setup, but rather in most of the resource-constrained countries, cost of immunosuppressive therapy using triple combination may exceed the total cost of bone marrow transplant. Eltrombopag has been used as a single agent with favorable responses. A response rate of 46% has been reported in a French study, while 62% response rate has been reported among EVMT member countries. Eltrombopag monotherapy may be used for in selected cases requiring IST, especially patients with renal dysfunction and active infection. Advantages are simplicity and relative safety, but the cost factor is prohibitive. Now, this is a list of various immunosuppressive therapies among resource-constrained countries, and the responses reported have been from 30% to more than 70% among various studies. A meta-analysis of 15 studies has shown that first-line match-related donor transplant is superior to immunosuppressive therapy among aplastic anemia. Allo bone marrow transplant should be the first-line treatment in patients who are less than 50 years of age with severe or very severe disease and have caused match-related sibling. There is better disease-free survival in younger patients undergoing match-related donor transplants when we compared with immunosuppressive as frontline treatment. With upfront match-related transplant, long-term survival in good center is more than 90% for young children and more than 80% for adolescents. For 40 to 50 years without match-related donor, and if the patient is more than 50 years of age with match-related donor, the frontline treatment would depend upon the individual risk factors like transplant risk factor, performance status, and disease severity. Older patients with very severe disease may be considered upfront transplant candidates if they are fit and have match-related donor. Haplodendrical transplants should be considered if match-unrelated donor is not available, but this should be reserved for centers having experience with haplodendrical transplants. At present, haplodendrical transplant remains the only practical alternate donor option for transplant in countries with restricted resources. The risk factors associated with poor transplant outcome are increasing age, longer disease duration, pre-transplant, higher transfusion burden, active infection, comorbidities, and disease severity. In addition, centers' experience and mismatched and alternate donor transplant are also important factors. Then there is availability of essential drugs and blood component that should be considered for deciding the treatment option. Match-related donor constitute the major donor source in developing countries, and availability may reach even more than 50% due to large family size. Match-unrelated donor and cord blood are not attractive options for resource-constrained countries, since likelihood to find a donor in the international unrelated donor registries are not good. Reason being that there is less representation of these ethnic groups among various donor registries. Then there is high cost and difficult logistics. There would be delay in finding suitable match, and of course there is a lack of expertise for match-unrelated donor transplant in most centers. Haplodendrical donors are readily available and virtually every patient has a donor. Recent reports comparing haplotransplant with match-unrelated donor transplant in children and adolescents reveal little difference in overall survival. Though haplo results are inferior to match-unrelated donor, but still the results are acceptable in patients who are not candidate for immunosuppressive therapy or have failed immunosuppressive therapy. Bone marrow is a preferred stem cell source for patients undergoing match-related donor transplant for aplastic anemia. Data for EBMT from EBMT and CABMTR shows superior outcome using the bone marrow versus PBSC grafts. In special circumstances, PBSC can be preferred source, like if there is donor-patient weight disparity, or we need early engraftment due to active infection, or there is high risk of graft failure due to alloimmunization. Some centers prefer GCSF primed bone marrow over PBSC. I personally prefer this source because we get higher CD34 count with no increase in GVHT. Compared to hematopoietic transplant for malignant diseases, higher doses are recommended for patients with aplastic anemia. The preferred dose should be greater than 3 CD34 count or more than 3 into 10 to the power 8 TNC dose. The optimal dose for haplotransplant has not been determined, but generally higher doses of more than 5 into 10 to the power 6 per kg CD34 cells are preferred. Choice of conditioning regimen depends upon type of transplant, patient's age, risk factor for graft rejection, comorbidities, and center's experience with the particular regimen. Standard regimen for match-related donor is cyclosporin 200 mg per kg and combined with ATG. Recent EBMT data suggests that survival of patients older than 40 years can be improved with addition of Fludara-based regimen in addition to ATG or Campath. Current EBMT guidelines recommend Flu/Cy with ATG or alemtuzumab for severe aplastic anemia older than 30 years of age for match-related donor transplants. Cyclosporin dose varies from 40 to 120. I personally favor 120 milligram cyclosporin dose. Where availability of ATG is problematic, fludarabine with Cy is an alternate source for conditioning. TBI is used for haplotransplant or alternate donor transplants and for patients with high risk of graft rejection. TBI option is not available in some BMT centers in developing countries. Recently, a phase 2 study has been launched on outcome of transplant, haplotransplant without TBI. Monitoring of cyclosporin and tacrolimus level is recommended. If the blood counts are robust, I would favor the cyclosporin level of closer to 200 milligram. For less than optimal blood counts, we would prefer closer to 300 nanogram per ml level of cyclosporin, and the corresponding level of tacrolimus are 10 to 15 nanogram per ml. To reduce the cost, we can go for the generic alternative of the calcineurin inhibitors. An important precaution is that the calcineurin inhibitor, they should be tapered off very slowly, and the tapering should not start before 9 months, and we should continue it at least 12 months post-transplant. These are certain considerations in resource-constrained countries. The viral infection are higher incidence, especially the CMV seropositivity is high among donors as well as patients, and there is high risk of CMV reactivation, especially following haplotransplants. And vigilant CMV monitoring and preemptive treatment is required. There is higher prevalence of hepatitis B and C in patients as well as donors that require appropriate viral hepatitis treatment and prophylaxis in transplant recipients. Then androgens can be used in certain selected cases as a bridge to transplant. Tranexamic acid can be used to reduce the severity of mucosal bleeding. Gynecological referrals are required in female patients. Again, generic azoles and antimicrobials and GCSF can be used to reduce the cost. Important thing is that we should limit the use of platelet transfusions to cutoff value of 5 in the absence of any significant bleeding. And blood transfusion should be limited unless the hemoglobin drops to less than 7 grams per deciliter. This is a proposed algorithm for the management of aplastic anemia. If the patient age is less than 40, has got match-related donor transplant, go for LOBMT. If there is no donor, match-related donor, immunosuppressive therapy can be offered. But if the patient is less than 20 years of age, we can go for match-unrelated or haplotransplant, depending upon the severity of the disease. Now, if the age is 40 to 50 years, patient has got match-related donor, go for transplant. If there is no donor, either immunosuppressive therapy can be offered, but in selected cases, we can go for match-related or alternate donor transplant. If there is very severe disease, there is less time and performance status is good. For patients who are more than 50 years of age, there is availability of match-related donor and good performance status. Age is less than 60, we can offer upfront transplant in selected cases. But for more than 60 years of age or there is no match-related donor, immunosuppressive therapy should be the first line treatment. If there is no response, again, we can go for match-related donor or alternate donor transplant, depending upon the various risk factors. If there is no donor, we, of course, second course of immunosuppressive therapy is given. And this was a last slide, and I thank you for your attention. If there are any questions, it's my pleasure to give answer to those questions if I'm able to answer those questions. Thank you.
Thank you so much, Dr. Parvez. As always, a great talk, and it was a much needed topic for all of us. We will take question and answer at the end of the session in panel discussion. Now, moving on to our next speaker, Dr. Syed Muhammad Irfan. He is a professor of hematology and working at Liaquat National Hospital and Medical College. He has more than 100 publications in reputed national and international journals and newspapers. He has also contributed to the National Transfusion Guidelines published by Sindh Blood Transfusion Authority. His special interests are myeloid malignancies, CLL, immune thrombocytopenia, blood component therapy. Dr. Irfan is going to deliver talk on an update on primary myelodysplastic syndrome. Over to Dr. Muhammad Irfan.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Irfan, and thank you very much to Dr. Bushra and her team for providing me the opportunity to talk in this PSH activity. And the topic of my talk is primary myelodysplastic syndrome. This is a brief update on the genetics and treatment options in primary MDS. We all know MDS is a unique disorder characterized by cytopenias and dysplasia, and the genetic abnormalities are important new addition to the diagnosis and prognostication and treatment planning and family counseling on primary myelodysplasia. Now, before primary MDS is an uncommon diagnosis. The secondary causes are 1,000 times commoner than the primary cause. So we need to rule out the nutritional causes, chronic infections, drugs, over-the-counter use of drugs, the locally available drugs, chronic illness, multi-organ failure, and all these things need to be ruled out, and only then you can think of MDS. Two important points I would like to mention here. Dysplasia may be seen in normal aged population. There are numerous papers available that dysplasia is a feature which is seen in advancing age. The significance, what is the significance of this? We are really not sure at this time, but we will see in subsequent slides. How does dysplasia help in reaching at a diagnosis? In cases who are not frankly MDS. And if we are not able to identify a cause of dysplasia, then we label it as idiopathic dysplasia of unknown significance, provided all other causes have been ruled out. Now, coming to the bone marrow, many a times we are stuck up while reporting the marrow, especially if it is hypocellular. And, only dysplasia at times is not very helpful in differentiating hypoplastic MDS or hypoplastic acute leukemia or aplastic anemia or PNH, etc. There is a new set of tests like, genetic testing and flow for primitive cells or PNH are really helpful in reaching at a diagnosis in hypoplastic condition. But even then, there are cases where we are not really sure what we are talking about, and we need to have a follow-up. And then during follow-up in 6 months or 1 year's time, we are able to reach at a better diagnosis. Now, the 3-4 slides about the colonal hematopoiesis and colonal cytopenias. This is a newer concept, and this is not unusual to have colonal hematopoiesis. Just focus here. This is normal bone marrow. Different colors show stem cells with different level of activity and function. In the young, this is the pattern. In the middle age, this is the pattern. In the elderly, this is the pattern. And this is sort of normal. But colonal hematopoiesis is this is the aberrant hematopoietic stem cell with strips, blue strips. So probably colonal hematopoiesis is a normal phenomena with age, but in most cases it is taken up by the immune surveillance system of the body, and the aberrant clone is eradicated. But in patients who are unable to eradicate this clone, it expands, it has a survival advantage, and it displaces the normal hematopoiesis. And so this is the coronal hematopoiesis. So if immune system eradicates here, the patient is here, elderly is here. If it fails to eradicate, there is expansion of the aberrant clone, and this is the coronal hematopoiesis which we are talking. Now, this is a pre-cancerous condition, and there are other well-known conditions which are precancerous in hematology, like MUGUS, like monoclonal B lymphocytosis, and now we are seeing a precancerous condition in myeloid malignancies also, and colonal hematopoiesis is one. We will see in further slides what we know more about this. Now, this is the prevalence of colonal hematopoiesis. These are 3 studies published by 3 different authors, and all 3 came to the conclusion that the risk of colonal hematopoiesis and expansion increases at 60 and above. You see here. These are the authors, and they further identified that rare before 40, and they identified the mutations also. What is the common mutations in colonal hematopoiesis, and DNMT3A, TET2, and AXL1. These are the mutations which they could identify in 2/3 of the cases. What significance they have, we will talk in the next slide. So we are talking of pre-MDS and pre-AML conditions. CHIP, colonal hematopoiesis, we have already talked. The 2 other conditions are ICUS and CCUS. ICUS is a more indolent state, idiopathic cytopenia of unknown significance, ICUS. It carries minimum risk of transformation to MDS or AML. CCUS is a different class. Here, there is not only cytopenia, but there is somatic mutations also. And mutations are more or less same as we identified in the CHIP. So this is one step ahead of CHIP. So there is more risk of transformation to myeloid malignancy in patients with CHIP and CCUS compared to ICUS. The highest risk is seen with the coronal cytopenia of unknown significance. This is the group. And this is the MDS. The patients who have all three criteria, cytopenia, mutations, dysplasia, increased number of blasts plus minus, and risk of transformation are labeled as MDS. Only cytopenia, ICUS. Only somatic mutations, CHIP. If both the things are there, the cytopenia and mutations, then it is CCUS. And if all the three things are there, then this is MDS. So now it is believed that these are precancerous conditions with maximum risk of transformation to MDS and AML in CCUS and minimal risk in ICUS. Now, what are the mutations which are seen in CHIP and CCUS? There are many mutations. If you do NGS on MDS patients, you will find about 100 mutations, but the commoner one are these. DNMT3A, TET2, and XL1, IDH1, IDH2, SBF mutations, and TP53 mutations, they are important. The important question is, does all patients with these mutations having CHIP and CCUS will transform to myeloid malignancy or not? To some extent, things are clear. The risk of transformation is minimal with DNMT3, TET2, and XL1, which is seen in more than 2/3 of cases with CHIP and CCUS. The risk is higher with IDH1, IDH2, SF mutations, and TP53 mutation. So it is not only the type of mutation, it is also the size of mutation, the size of clone that determines the risk of transformation of these pre-MDS conditions into MDS. And also it has been seen that patients who harbor more than one driver mutation, they are more likely to transform than patients who has got one mutation. So nothing to worry, nothing to be scared of, and no question of anxiety if somebody is found to have these mutations, because there are other factors which I have told you, and there are still others which are to be discovered. So when we see the MDS and the landscape of mutations, MDS is very wide. Many of the mutations are same as we have seen in the CHIP and CCUS. And I have told you that the risk of transformation is minimal with CHIP and maximal with CCUS. And also the type of mutation, size of mutation, and more than one mutation. So MDS is a disorder with overlap conditions. IDUS, idiopathic dysplasia of unknown significance. CCUS is on one hand, CHIP is on the other hand, ICUS is on the other hand. Probably MDS is not a disease entity arising itself. Maybe in the times to come, we will see it is a indolent, slowly emerging disorder. It takes years and decades to be clinically, to manifest clinically. And maybe we will have better data to correlate these precancerous conditions with the MDS. Now, these mutations also affect the outcome. There are numerous papers. We will not go in detail for time reasons, but this blue line shows the normal cytogenetics, no mutation. So the survival is maximum and better for those which do not harbor any mutation compared to those which have got, for example, P53 mutation. This is red. So the poorest survival is seen with P53 and best is seen without any mutation. Other fall in between. So mutations can be correlated with the prognosis and outcome. Though these mutations are not incorporated still in IPSS revised score system, which is mainly based on cytogenetics, number of blast cells, and other hemoglobin, etc., etc. Maybe the new classification will incorporate the mutational status also, and we have better prognostication of primary MDS. Now, this was about the genetics of CHIP, CCUS, and MDS. Coming to the treatment options, this is a chart from British Society of Haematology guidelines. The patients with low, very low, and intermediate risk. Uh, Here, the supportive care remains the mainstay of treatment, will not go in detail. Just the key point, it is preferable to give irradiated blood and leukodepleted blood than the routine blood. The other thing is the iron overload. The best drug for iron overload in such patients is Defracirox, not Defriprone because it is associated with neutropenia and agranulocytosis. So anemia is mainly handled with either transfusion or transfusion, minimal transfusion and erythropoietin. You can combine in 4 to 6 weeks time with GCSF. If the response of erythropoietin is not satisfactory, it is given in higher doses, 30,000 to 60,000 units per week. Lina, we will talk for anemia. Lina will talk in the next slide. The another compound for anemia is the luspatercept. We will talk in the next slide also. For thrombocytopenia in low-risk patients, it is best to avoid platelet as in prophylactic setting. And Lina and Eltrembopag has been identified as a good drug in patients with low-risk disease to increase the platelet count. In hypoplastic MDS, ATG, cyclosporin, or other immunosuppressive agents may be helpful. So this is about the lenalidomide. 5q- syndrome is a distinct hematological disorder, mainly affecting females, macrocytic anemia, bone marrow characterized by small monolobated lymphocytes, 5q- as a unique abnormality, most responsive to the lenalidomide. Not a very expensive drug, not a toxic drug, not as a chemotherapeutic drug, and it is well tolerated also. So this is the unique sort of type of MDS. It has the best outcome. Mean survival is something around 8-9 years. Now, luspatercept is the new addition, tried in patients with thalassemia initially, and now approved by the EME and FDA in MDS patient. This is a trial, randomized trial, phase 3, luspatercept 53 patient and placebo 76 patient. Primary endpoint was to see transfusion independence in first 24 weeks. 38% patients were transfusion independent at about 8 weeks time, and in 48 weeks follow-up, it was found that 28% patients were transfusion independent for 16 weeks. So this was the initial endpoint, more than 8 weeks of transfusion independence, and this is the follow-up, and this is a this is the drug which has been approved in MDS patients. We have no experience of using this drug here in our center in Pakistan. Now coming to the high risk MDS, not much has been done for patients with high risk disease. Transplant remains the only cure, and you can try myeloablative transplant or you can try RIG transplant. Whether to give, pre-transplant Chemo to attain remission is determined by the number of blast cells. If more than 10, do give chemo hypomethylating agents and then go for transplant. If blasts are less than 5%, you can straight away go for transplant. And in between blast population, that is your individual decision. Transplant is curative, uh, some 40 to 50% patients are cured for 2 years or more. But since the disease affects the elderly population, not many patients are, eligible for transplant. Other options here are supportive care. Hypomethylating agents are again good. We will see in next slide how it is helpful. This is the HMA. Azacitidine is the preferred drug because most of the data favors the use of azacitidine. This graph shows conventional care. This green line shows azacitidine. Some advantage of, is seen by the addition of azacitidine. Some 1 year survival benefit is evident in this graph. This is a historical study. And this add to about 1 year survival to patients who are high risk and compared to the conventional management. So this is the good drug. It is also used to bridge and control the disease in patients for transplant also. And this is to be given if the response is there, you need to give for a longer time. 75 milligram per meter square is the dose. Now, more recently, venetoclax is being used widely for CLL and lymphomas and AML. It has also been tried in MDS also, and we see some 6 month survival benefit compared to azacitidine alone. 6 month benefit is seen in patients who tolerate. This drug caused tremendous cytopenia, and patients with MDS are already cytopenic, have ineffective hemophilia. So that is the main problem in the management of patients who receive AZA plus venetoclax. Now, transplant, again, that is the only cure. As I told you, this is the RIC-MAC trial. This is the famous trial. Prospective 129 patients, engraftment was comparable. This is the relapse-free survival, and this is the overall survival. The source of stem cell gives the similar outcome in MDS patients with high-risk disease. Also, the progression-free survival and overall survival remains same. So probably RIC should be reserved for patients who are really elderly and have got co-mobs and they are relatively frail. And myeloablative can be tried in patients with who are relatively healthy. Yellow is MAC, myeloablative, and blue is RIC. Now, other treatment options for high-risk patients are AML type therapy, 3+7, or some modification. Again, you need a good health to try this type of therapy. This may not be curative in MDS. Cytosar, low dose, and melphalan are relatively out now, replaced by the azacitidine. L-Trembopag is a good choice in MDS patients. In low-risk MDS to increase the platelets. It is not indicated in high-risk MDS patients. Steroids if immune manifestations. Immunosuppressive therapy in hypoplastic MDS. This is a difficult decision. One should be careful. Targeted therapies are emerging, and CAR T cell are not promising so far. So to conclude, diagnosis of primary MDS be made carefully unless there is strong evidence like blast cell or marked dysplasia, etc. Patients on the part of the physician and the family, and extensive workup is required to rule out secondary causes. Pre-MDS entities, which I've recently told, the CHIP and CCUS need consideration and require NGS testing and follow-up in most cases. As far as treatment in low-risk patients, wait and watch, supportive care, and specific drugs specifically significantly add to quality of life and overall survival. For high-risk cases, better options are required to improve survival and potential cure. I thank you very much, the organizer and the audience. Thank you.
Thank you so much, Dr. Irfan. It was very informative talk and one of the most valuable addition in this PSH forum. Thank you so much again. Now I would like to start a panel discussion. I have a few questions. My first question is from Dr. Ghulam Nabi Kakepoto.
Yes, dear.
Sir, how are you, sir?
Yeah, I'm fine, thank you.
Thank you for joining us. Question is, ribosomopathies are consistently seen in inherited bone marrow failure syndrome. What is the link of ribosomopathies with causation of cancer in bone marrow failure syndrome?
This leads to really the activation of, if you can, I don't know whether we can bring the slide back, but this leads to the activation of the oncogenes and leads to the telomere to be unstable, and that leads to the apoptosis of the cells, particularly in the rapidly dividing cells. Like so, these children typically present with bone marrow failure syndrome, and also they have other hallmarks of the disease, like I have mentioned in my talk, with short stature and other somatic problems.
Ji, sir. Thank you so much. My second question is, sir, hello, Dr. Nadeem. Now, can you hear me?
Dr. Nadeem, unmuted कर ले अपने आप को, जरा सा देखें. चलें, you can continue your discussion.
Ji. Dr. Irfan, you have. Assalamu alaikum, Dr. Irfan.
जी, Assalamu alaikum, Dr. Sir. Assalamu alaikum.
Ji, sir, how are you?
जी, very well. Allah का शुक्र है. Enjoying the session since morning.
Sir, in your presentation, you have used few terms like ICU, CCUs, and CHIP, which are pre-malignant for primary myelodysplastic syndrome and leukemias. So, could you please elaborate them more?
Sure, why not? Actually, these are new terms in use for the last 8-10 years, but they have been associated with MDS more recently. And two important terms are CHIP and CCUS. CHIP is coronal hematopoiesis of indeterminate potential, and CCU is coronal cytopenia of unknown significance. So both are considered pre-malignant conditions, and it is just like, monoclonal B lymphocytosis in case of CLL, which can transform into CLL. So this is the first time that we have identified pre-malignant conditions for the myeloid disorders. CHIP is relatively mild. CHIP simply means that there is a mutation, underlying mutation, but patient is not symptomatic. There are no cytopenias, there are no dysplasia, and patient is not symptomatic. There are numerous papers on this, and this is typically associated with age. With increasing age, there is more, coronal hematopoiesis. Perhaps this is a normal phenomena, but body takes up the abnormality, and in most cases, the abnormal clone is, eradicated. But in some cases, clone persists, there is survival advantage, and such patients carry the particular genetic defect. And whether they will become symptomatic in future or not, it is difficult to say at this time, but there are factors which can predict who is likely to transform and who is not. CCU, on the other hand, is a next step. In CCU, not only there is a genetic defect, there is cytopenia also. And the model which is emerging is like it is CHIP, CCUS, low risk MDS, high risk MDS, and finally AML. The mutations which are associated are many. There are about 20, 25 mutations. The commonest one, however, are relatively non-toxic. Non-toxic means these common mutations, patients who are, the individuals who are harboring these mutations, they usually do not transform. And these mutations make about 2/3 of the mutations. Usme important is TET2, DNMT3 and ASXL1. ये three mutations हैं which are seen in about 2/3 of the population in aged people. Other mutations which are not common but may carry the higher risk of transformation to MDS, and they are IDH1, IDH2, TP53, and SRSF3. These are the mutations which carry the higher risk. So it is the type of mutation. Number two, it is the size of the clone. That is also important. And third is the multiplicity of mutations. If there are more mutations, there is more chances of transformation to MDS and AML. So this is all about CHIP and CCUS and MDS.
Okay, thank you, sir. Sir, your talk was very informative. It was really great pleasure to listen from you. And now I have another question, and I would like to direct this question to Dr. Farrukh Ali Khan. Assalamu alaikum, sir. Please, sir, how are you? Sir, unmute your mic, please.
Alhamdulillah,
Hello?
I'm fine. How are you? Wonderful talks.
Thank you so much, sir. Sir, as you are actively doing in transplant in one of the public sector here at Pakistan, the question is, what are the future directions for aplastic anemia transplant in Pakistan?
Well, I think in aplastic anemia, if you see as overall as a disease, it is the second most indication of bone marrow transplant in Pakistan after thalassemia. So it is genuinely our problem. Now, at the same time, if we see, we have actually two challenges in like one is the financial support for the patients, especially the delays which we are getting in doing the transplant. Now we have our own very good data to support it, that the outcome of transplant in aplastic is exceptionally very well, almost 80% success rate. So this disease should be taken like differently in comparison to other transplant. You don't need to give the chemotherapy to attain some type of remission like we need for the leukemia and the other malignant conditions. You can take the patient upfront for the transplant. So I think we are basically lacking in getting those patients for transplant as soon as possible. That leads to, in half of the patients are almost, they are sensitized. It becomes platelet refractory by the time they go for the transplant. So if we can get the quick and fast track approval, I'm talking about the public sector especially, because we heavily rely on the approval from the government. If we can make a track and tell them that the outcome is really good for aplastic anemia in transplantation, so maybe we can shorten that delay and get much better results. The second thing is that I think the outcome of matched unrelated donor transplant is also very good in aplastic anemia. We are not doing it here because we have the donor registry, but for aplastic especially, if you see the literature, there are few studies which are actually reporting the outcome is as good as the matched sibling donor transplant, especially in the kids. So I think this is another area where we need to work in the future.
Okay, thank you, sir. Sir, what would you like to say, even after transplant, the outcome of aplastic anemia is still poor? Sir, can you please highlight it?
You mean that after the bone marrow transplant?
Yes, in aplastic anemia here at developing countries, especially in Pakistan,
Actually,
still we
I think
see the
the major
outcome.
reason, I think the major reason is again the delay. Because if you do the transplant in initial 3 months, then definitely you will get very good outcome. But once the patients become and go through the multiple transfusions, platelet or PET cell, and develop the antibodies, then the outcome becomes poorer. So again, because two factors actually. One is that we need to refer those patients quickly to the hematologist, but unfortunately, we don't have a primary healthcare setup here. The people usually go by themselves to hematologists. That we can't control. But the other point is, once we have the diagnosis, then we need quick approvals for getting the treatment, for doing the transplant for those patients. I think that area we can cater, and we need to target and take up this issue.
Okay. So the delay in transplant from the diagnosis is the major reason. Thank you, sir. Thank you. Ji, Assalamu alaikum. My next question is from Dr. Nadir. Assalamu alaikum, sir.
Assalamu alaikum.
How are you, sir?
I'm fine today. How are you, madam?
Alhamdulillah, sir. Thank you for joining us. Sir, I would like to direct this question to you. Low-risk MDS is still kept on transfusion support only. Many can't afford a standard dose of epochine and mostly don't offer. Sir, what is your experience? Sir, could you please highlight this issue?
Thank you. Thank you very much.
We are talking in our scenario.
Yeah. In Pakistani scenario, first of all, when a patient of MDS transfusion dependent comes to us, we have to verify the diagnosis as well. Many of the patients are labeled myelodysplastic syndrome on the basis of dysplasia and bone marrow only. And later on, we find that these patients were not actually the patients with myelodysplastic syndrome. Especially low-risk patients, many of these patients are having the transient myelodysplasia, and at times they become the transfusion dependent as well. Second, while we are putting the patient on transfusion and the erythropoietin, we have to again reassess the patient, whether this patient is going to respond to the epochine or not. So first of all, many of the studies show that the patients with low erythropoietin levels, they will respond to erythropoietin stimulating agents better than the patients having already high levels of the erythropoietin. So we have to reassess them. Patients with no cytogenetic abnormalities or milder cytogenetic abnormalities or good cytogenetic abnormalities, they are going to respond better to the erythropoietins than the patients with bad cytogenetics. The patients with very high ferritin, they are going to respond lesser than the patients with the lower iron overload. So similarly, the patients with the blast count. Many times we have seen that the patients with higher blast counts even, they revert back to the lower blast count as well. So initial workup done on these patients is very important. Just putting them on transfusions or putting them on erythropoietin is not wise. Now, once we decide to put these patients on erythropoietin and transfusions, we can combine the strategy that transfuse them and put them on lower dose of the erythropoietin. And if they are responding, then you go the higher doses of the erythropoietin. And if the patient is requiring higher doses of the erythropoietin, it means the patient is not low risk or intermediate risk. Maybe it is possible that this is a high risk patient and we are just wasting the erythropoietin on them. Now, alternative to the erythropoietin, people had tried the low dose steroids, then the anabolic steroids like Darazole. And to some extent, people have tried the lenalidomide in 5q minus syndrome. And even non-syndrome patients, even non-5q minus, lenalidomide works very well. I hope I had answered the question. Thank you.
Yes. Okay, sir. Thank you so much for your detailed answer. We have General Parvez with us. Sir, Assalamu alaikum, sir.
Muted.
Sir, kindly unmute your mic.
Am I audible?
Yes, sir. Assalamu alaikum, sir. How are you?
Walaikum salam. Sorry, there was some connectivity problem with. I'm not IT friendly. I'm a bit old person.
It's okay, sir. Sir, I have a question and I would like to direct this question to you. How you differentiate hypoplastic myelodysplastic syndrome from aplastic anemia in your practice? And what is your experience about difference in management of these two disorders?
A very difficult question to answer. Dr. Irfan has already, explained about the difficulty that we encounter. That the main thing is if we find the genetic abnormalities and a dysplasia. Mild dysplasia, especially erythroid dysplasia, is not infrequent in idiopathic plastic anemia. But if there is anything more than the isolated erythroid dysplasia, and even if we don't find any cytogenetic abnormalities, likely diagnosis would be the hypoplastic MDS. Management, of course, we would prefer to treat that patient with the transplant, bone marrow transplant. The only difference would be that we would like to give the more intensive conditioning in hypoplastic MDS compared with the RIC in aplastic anemia. I hope I have answered the question.
Hello, sir. Can you hear me?
Yes.
Yes. Thank you, sir. Thank you for your question, for your detailed answer. Sir, I have another question that is hypoplastic MDS or aplastic anemia in elderly. So what is your experience of treating hypoplastic MDS in elderly? Not or the patient not eligible for transplant?
Patient for not eligible transplant, they have got dismal prognosis. The option available is the supportive therapy with the addition of altrumubag.
Okay, sir. Thank you so much. Now I welcome Professor Iqbal, Waseem Iqbal is also with us. And I have a question, and I would like to direct this question to Professor Dr. Waseem Iqbal. Sir, what factors contribute to poorer treatment outcome even after transplant in Pakistan?
Well, Dr. Parvez has clearly elaborated regarding the poor outcome or response in aplastic anemia. Main thing is the lack of supportive care or suboptimal supportive care. Like, for example, treatment of infections, bleeding arising, or any backup transfusion services. But generally speaking, the severity of aplastic anemia at the time of initiation of therapy, for example, whether it is severe aplastic anemia or very severe aplastic anemia, then age of the patient is also important to actually predict the outcome of either immunosuppressive therapy or stem cell transplantation.
Thank you, sir. Thank you so much. Dr. Nadeem, Assalamu alaikum. Can you hear me?
Yes, I can hear you. Can you hear me?
Yes, sir. I can hear you now. Okay.
That's good.
Okay, Dr. Nadeem, kindly, I welcome you to join us, and please have some comment, and I'm really happy to having concluding remarks from you.
I am extremely grateful to all of the speakers. They have given very good presentations. Dr. Ghulam, Nabi, Kakepoto, Dr. Parvez, and Dr. Irfan. Just I'd like to mention one point. I think we are talking about now, we are living in an era of molecular genetics and cytogenetics. The problem with us is that we don't have a standardization of these tests. Just in one of the speaker, I think a foreign speaker, where the question was posed that there is a patient with high hematocrit and he doesn't require phlebotomy and JAK2 positivity. So what should we do? So again, the problem is whether this JAK2 positivity was, when it was done in the lab, was really right, or whether it's what false positive result. Same is the case. I remember I received a patient of classical CM1, and somebody in a lab, we did this this BCR-ABL, and that turned out to be negative. But when we repeated it, it again turned out positive. So one has to be very, very cautious about interpretation of this genetic testing, and especially ordering this genetics testing, whether we should order it, because Dr. Irfan has mentioned in many conditions, we don't have the option of changing the management. If we cannot change the management, then why should you waste the money? Because most of the centers, these tests are done in a private center and they charge a huge amount. So we should be very, very, very careful in ordering these genetics. That's what I just want to have a comment about these testing facilities in our country. And I will thank you, all the speakers, and I also must thank Dr. Sana. She has conducted the session very well. And all the speakers, I am extremely grateful. Thank you very much.
Thank you so much, sir.
Thank you. Well done,
Thank you, Dr. Ghulam, Dr. Parvez, Sir Nadir. Thank you, Dr. Waseem, Dr. Farrukh. Thank you so much. Allah Hafiz.
Thank you very
Well
much.
done, Doctor. Well done.
Very good.
Well
Very
done,
well
Doctor.
conducted
Very
session.
well done.
Yeah.
Congratulations.
Yeah. Excellent session.
Excellent session.